Hey, Radonc crew. Welcome back to Radonc's Smart Review RadBio edition.
Hello, everyone.
We're two Radonc attendings, and today we're really going to get into some core radiobiology, stuff that's, super important not just for your boards, but really for day-to-day clinical practice.
Absolutely. We're focusing on two pretty different radiotherapy techniques today, specifically looking at them through a radiobiological lens.
Right. First up is Intensity-Modulated Radiation Therapy, IMRT, which, is basically standard practice now.
hmm And then we'll jump into something really cutting edge, FLA-ESH radiotherapy, this
Yeah.
ultra-fast delivery concept that's generating a lot of buzz.
Yeah, exactly. So the plan is to kind of break down the radiobiology for each one. What are the underlying principles? What are the potential trade-offs?
And maybe peek a little bit into the future, especially with LASH. It's all about understanding the why behind these techniques.
Definitely. Should help you sharpen those concepts for exams and just feel more confident when you're planning or reviewing treatments.
Okay, so where should we start? IMRT.
Yeah, let's start with IMRT. It's, like you said, the workhorse. You see it everywhere.
Right. And its main goal, fundamentally, is about dose confirmation, isn't it?
Exactly. Getting that radiation dose shaped really tightly to the tumor, especially when you've got complex target shapes or critical organs sitting right next door.
And sparing those nearby normal tissues. That's the key advantage people think of.
It achieves this using, multiple beams, often from many different angles. And within each beam, the intensity is modulated, changed across the field.
Little beamlets, essentially, with different intensities.
Tiny segments, some blocked, some open, to build up that complex dose shape.
But that incredible precision, that ability to sculpt the high-dose region, well, it comes with some radiobiological considerations we need to talk about.
For sure. And the first thing you usually notice when you compare an IMRT plan to, say, a standard 3D conformal plan.
The monitor units.
Yeah, the MUs. They're way higher, right?
Yeah. Oh, definitely. You'll often see, like, 2 to maybe even 10 times the number of monitor units compared to a simpler 3D plan for the same target dose.
And why is that? It's because of all those small segments.
Exactly. You're using lots of tiny fields, often blocking large portions of the beam to create those specific intensity patterns. So to deliver the same target dose, the machine just has to be on for longer. More MUs.
Okay, so the machine's on longer. What does that lead to radiobiologically?
Well, more beam on time means more contribution from things other than the primary beam hitting the target. Specifically, head leakage radiation from the linear accelerator itself.
Right, radiation leaking from the treatment head.
And also increased scatter radiation within the patient's body. Now, the dose rate from leakage and scatter is low, but because you have so many MUs.
A total dose contribution from them adds up. It's not negligible.
Precisely. And importantly, that extra dose is spread out.
Which leads us right into probably the most talked about radiobiological aspect of IMRT.
The low-dose bath.
The low-dose bath, yeah. Can you explain that concept?
Sure. So IMRT is, as we said, really good at reducing the high dose to organs immediately adjacent to the target volume. But because you're using beams from so many angles and modulating the intensity so much, you often end up delivering a low to moderate dose to a much larger volume of normal tissue that's further away from the target.
So you spare the neighbor, but you kind of splash a little bit of dose over a wider area.
That's a good way to put it. You've contained the high-dose spill, but you've created this sort of low-dose bath that covers a bigger region of healthy tissue.
And how does that affect the overall dose to the patient? What about integral dose?
Right, the integral dose, which is the total energy absorbed by the patient's entire body. It's a bit complex, because a well-designed IMRT plan can be better than a poorly designed 3D plan.
Okay.
But often, compared to a well-designed 3D conformal plan, a complex IMRT plan might actually have a higher integral dose.
Because of that low-dose bath spread over such a large volume.
Exactly. Even though the dose per unit volume is low in that bath, the total volume receiving it is much bigger, so the total energy absorbed can increase.
Okay, so we have this larger volume getting low dose, potentially higher integral dose. What's the main long-term clinical worry associated with that?
The big one is the potential for secondary radiation-induced malignancies, cancers caused by the radiation itself years or decades later.
Right. And this goes back to fundamental radiobiology. Radiation is a known carcinogen.
Yep. It can damage DNA and potentially initiate the cancer process, We classify cancer induction as a stochastic effect,
Stochastic meaning.
meaning the probability of it occurring increases with dose. But if it does occur, the severity or type of the cancer isn't necessarily related to the dose. It's more of an all-or-nothing risk that goes up with exposure.
Got it. And how do we typically model that risk, especially at these low doses we're talking about in the bath?
The prevailing model, though it's debated, is the linear no-threshold model, the LNT model.
Linear, no threshold. So linear meaning the risk is proportional to dose.
Right. Double the dose, double the risk, roughly.
And no threshold meaning?
Meaning the model assumes there's no safe dose. Any amount of radiation, theoretically, carries some increased risk, however small.
Okay. So if we apply that LNT model to IMRT's low-dose bath.
Then that larger volume of normal tissue getting some dose, even if it's a low dose per cell, translates into a higher overall probability of inducing a secondary cancer somewhere in that volume compared to a technique that irradiates less normal tissue in total.
Even if that other technique gives a higher dose to a smaller volume of normal tissue.
Potentially, yes. According to the LNT model, applied simplistically, it's the total number of cells hit that contributes to the overall population risk.
And this risk becomes particularly important for certain patient groups, doesn't it?
Absolutely critical. We worry most about pediatric patients, children, and also young adults. Basically, anyone with a long life expectancy ahead of them.
Because they have more years for that potential secondary cancer to actually develop and become a clinical problem.
Exactly. Decades of life ahead means decades for that stochastic risk to play out.
There have been studies modeling this, right? I remember seeing work looking at pediatric cranial spinal irradiation.
Yeah, there was a notable modeling study, I think by Athar and colleagues around 2011, published in the Red Journal. They predicted a significantly higher lifetime attributable risk LAR for secondary cancers with IMRT compared to intensity-modulated proton therapy, or IMPT.
And the difference was mainly attributed to the protons depositing less dose overall outside the target, less integral dose.
Precisely. Protons stop more abruptly, so they tend to have a much lower integral dose and less of that low-dose bath compared to photons, which is why they're often favored in pediatrics when available.
Okay. Quick side note on secondary risk, what about neutrons? We sometimes use higher energy beams.
Good point. For photon beams with energies above about 10 mega electron volts, and particularly above 15 MeV, you can get what are called photoneutrons produced.
Generated in the machine head or even in the patient?
Both, yeah. Now, the actual absorbed dose from these neutrons is usually very small.
But
Neutrons are biologically much more damaging per unit dose than photons. They have a high radiation weighting factor, or RBV. So their contribution to the overall secondary cancer risk, while generally considered minor compared to the scattered photon dose, is definitely not zero, especially with those higher energies.
So summing up IMRT radiobiology, there's a clear trade-off we're making.
Absolutely. You gain fantastic dose conformity right around the target, really excellent sparing of nearby critical organs from high doses.
But the cost, radiobiologically, is potentially a higher integral dose and exposing a larger volume of normal tissue further away to that low-dose bath.
Which, according to the LNT model, translates to a theoretically increased risk of secondary malignancies down the road.
A risk that weighs more heavily the younger the patient and the longer their expected survival.
It's the constant balancing act in clinical radiotherapy planning.
Okay, that's a solid look at IMRT. Now let's shift gears completely. Let's talk about FLASH-H radiotherapy.
All right. This is definitely one of the most exciting areas of research right now. Very different principles at play.
And the absolute defining feature of FLASH-H's.
The dose rate. It's all about speed.
How fast are we talking?
Ultra fast. Conventional radiotherapy delivers dose at rates maybe around 0.03 to 0.1 gray per second. Or if you think in minutes, like 2 to 6 gray per minute, kind of a steady delivery over minutes.
Okay. And LSH?
FLASH radiotherapy is typically defined as delivering radiation at dose rates greater than 40 grays per second.
40 grays per second? That's hundreds of times faster.
Orders of magnitude faster, yeah. We're talking about delivering a significant dose in less than a second, often in milliseconds. It's like an intense pulse of radiation.
Wow. And why the excitement? What biological effect does this incredible speed seem to cause?
The main finding, the thing that got everyone so interested, is what's called the flash effect. Consistently, across many preclinical studies, researchers are seeing significant sparing of normal tissues compared to the same dose delivered at conventional dose rates.
So, less damage to healthy organs.
Right. And this is the crucial part, maintaining equivalent, or in some cases possibly even enhanced, anti-tumor efficacy.
Ah, so it's a differential effect. It seems to hurt the tumor just as much, maybe more, but hurts the normal tissue less.
That's the promise. Improving the therapeutic ratio, that's the holy grail in radiation oncology, right?
Absolutely. More tumor kill, less normal tissue toxicity. Where has this been shown?
The preclinical evidence base is actually quite broad now. It's been seen in various animal models: mice, zebrafish, cats, pigs, mini pigs.
Okay, so not just one species.
Right, and with different types of radiation too. Electrons were first, but it's also been shown with photons and protons.
And in different tissues.
Yeah, sparing has been demonstrated in organs like the lung, the brain, skin, the intestine. So it seems to be a fairly robust phenomena, at least preclinically.
The potential clinical implications are obviously huge if this translates to humans.
Immense. You could potentially escalate tumor doses significantly without increasing side effects, leading to better local control.
Or you could give the same tumor dose, but with much less toxicity, making treatment more tolerable, maybe allowing for more aggressive hyperfractionation.
Exactly. Or even treating tumors that are currently considered untreatable because they're just too close to critical, sensitive, normal structures.
Okay, so the big question then is how? What are the proposed mechanisms behind this alpha-Elish effect? Why does delivering dose so quickly spare normal tissue?
That's the million-dollar question, and it's still an area of very active research. There isn't one single universally accepted mechanism yet, but there are some leading hypotheses.
What's the front runner?
The one that gets discussed most often is probably the oxygen hypothesis.
Okay, related to oxygen levels in the tissue.
Yes, the core idea is that this massive, ultra-high dose rate burst of radiation consumes intracellular oxygen incredibly quickly.
How does it consume oxygen?
Through the instantaneous creation of a huge number of oxygen-dependent free radicals, like peroxide radicals, this rapid consumption outpaces the cell's ability to replenish oxygen from the surrounding vasculature during that very brief pulse.
So it creates a temporary, very short-lived lack of oxygen within the normal cells during the radiation pulse.
Exactly, a state of acute transient hypoxia, just for milliseconds, maybe seconds, right when the radiation is being delivered.
Okay, maybe an analogy helps here. Imagine normal tissue oxygen is like fuel in a race car engine that's constantly being refilled from the tank. Conventional radiation is like running the engine. Normally fuel gets used, but the tank keeps it topped up.
Okay.
FLESH is like hitting the nitro boost. It burns through all the immediately available fuel in the engine cylinders almost instantly before the fuel line from the tank can catch up and refill them. Just for that moment of the boost, the engine runs out of fuel locally.
That works. So you get this transient oxygen depletion in the normal cells. Why does that spare them?
Because oxygen is a potent radiosensitizer. It fixes radiation damage, making it permanent and harder to repair, particularly via free radical pathways.
Right, OER, the oxygen enhancement ratio.
Exactly. So if you temporarily make the normal tissue hypoxic during that radiation pulse, you make it more radioresistant, less sensitive to the damage being caused by that same pulse.
Okay, that makes sense for normal tissue, but why wouldn't the tumor get the same protective benefit?
That's the key to the differential effect. Tumor tissues are often already chronically hypoxic. They live in a low oxygen environment to begin with.
Poor vasculature, high metabolism.
Right. So that extra transient dip in oxygen caused by alpha-LHH might not change their radiosensitivity as much because they're already somewhat radioresistant due to hypoxia. Or perhaps their baseline metabolic state or antioxidant capacity is different, making them react differently to that rapid oxygen consumption.
So the difference in oxygen status and kinetics between normal and tumor tissue is exploited by the ultra-high dose rate.
That's the core of the oxygen hypothesis. It's quite elegant.
It is. What are some of the other mechanisms being proposed?
Another significant one involves differences in how free radicals behave at these ultra-high concentrations. It's sometimes called differential radical recombination or interaction.
Okay, what's the idea there?
At conventional dose rates, you create radicals, and they diffuse around until they hit a biological target like DNA or react with oxygen. At Felly-Esch rates, you create such an incredibly high concentration of radicals all at once in a very small space.
So they're more likely to bump into each other.
Exactly. The theory is that radical interactions, like two radicals recombining to form a stable, non-damaging molecule, become much more probable compared to radical target interactions. They essentially neutralize each other before they can do as much damage.
And this effect might be different in normal versus tumor cells.
Potentially, yes. maybe due to differences in baseline antioxidant levels, diffusion distances, or the specific types of radicals produced. The idea is that this self-neutralization spares normal tissue more effectively.
Interesting. So the radicals are kind of mopping each other up.
That's one way to think about it. And beyond oxygen radicals, people are looking into other possibilities too.
Like what?
Things like differential effects on the immune system response, potential changes in DNA repair kinetics or pathway activation at these extreme dose rates, maybe differences in inflammatory signaling, or effects on specific cellular components like mitochondria.
So it's probably complex, not just one single thing.
Almost certainly. It's likely a combination of these factors, and maybe the dominant mechanism even varies depending on the specific tissue type. The total dose, the exact dose rate, fractionation, lots of variables.
Yeah, the field is really working hard to tease all that apart right now.
Okay, maybe a quick mnemonic to help remember the key 5-FLASH-ESH concepts. How about FLASH?
Okay, let's try. F could be for fast,
Mm,
ultra-high dose rate, greater than 40 Gs.
good.
Low toxicity, that's the normal tissue sparing effect. Anti-tumor efficacy,
Mm,
maintained or maybe even enhanced.
okay.
Sparing, reinforces the normal tissue sparing.
Okay. And
Hypothesis, like the oxygen hypothesis being a leading explanation.
FLASH, fast, low toxicity, anti-tumor, sparing, hypothesis. Not bad.
Works for me.
Yeah.
Helps keep the core ideas straight.
All right, let's pull this back to the clinic. How does all this radiobiology influence actual clinical decisions? Starting with IMRT, which we use every day.
With IMRT, the decision-making is really centered on that trade-off we defined earlier. You're weighing the benefit of superior dose conformity and sparing of nearby critical structures.
Against that downside of the low-dose bath and the potential long-term risk of secondary cancers, especially considering the patient's age and life expectancy.
Exactly. Let's take a mini-case. Imagine you have, say, a 10-year-old child with a tumor right next to the optic chiasm.
Okay, critical structure for vision. You absolutely need to spare that. IMRT could give you a beautiful sharp dose fall-off right at the chiasm edge.
Right. But that child has, hopefully, 70, 80, maybe more years of life ahead. That theoretical increased risk of a secondary cancer developing somewhere in that low-dose bath decades from now becomes a really significant factor in the discussion.
So you'd be thinking hard about alternatives too, like protons, if available.
Definitely. You'd strongly consider protons precisely to reduce that integral dose, minimize the low-dose bath, and lower that lifetime attributable risk while still achieving excellent chiasm sparing. The long-term risk is paramount.
Now contrast that with, say, an 80-year-old patient with a similar tumor location.
For the 80-year-old, the calculation shifts dramatically. While the secondary cancer risk isn't zero, their limited remaining life expectancy makes it much less likely to ever become a clinical issue.
So the focus shifts more towards the immediate benefits.
Exactly. The immediate benefit of IMRT in reducing the dose to the chiasm now, preventing blindness or severe vision impairment within their likely lifespan, and minimizing other acute or subacute toxicities probably outweighs that much smaller, longer-term secondary cancer risk.
So the patient's age and expected survival are huge modifiers in how you apply the radiobiological principles of IMRT.
Absolutely fundamental to the risk-benefit assessment.
Okay, what about FLASH? How does its radiobiology impact clinical decisions today?
But today, FLASH is still primarily preclinical or in very early phase human trials. So it's not really impacting routine clinical decision-making for most patients yet.
Its relevance is more about the future potential then.
Exactly. The clinical relevance now is understanding its potential promise. If it pans out, it could fundamentally change how we approach treatment.
Like boosting the therapeutic ratio.
Right, allowing dose escalation for resistant tumors,
Well,
or maybe making extreme hyperfractionation much safer by dramatically reducing normal tissue effects.
or treating near very sensitive structures that are currently dose limiting.
Precisely. The potential is huge. But, and it's a big but,
There are hurdles.
significant technical challenges remain. Delivering those ultra-high dose rates accurately, conformally, and reliably to deep-seated tumors in humans is not trivial. Machine development, dosimetry, treatment planning, it all needs work.
And we still need more biological understanding and robust clinical data in humans.
Absolutely. We need to confirm the effect translates, understand the optimal parameters, dose rate, dose per fraction, total dose for different tissues and tumors, and assess long-term effects. It's a major focus of research, but it's not ready for prime time across the board just yet.
Okay, that clarifies the current status. Let's shift now to some really high-yield takeaways. Time for clinical pearls.
All right, distilling it down, what absolutely needs to stick.
Pearl number one, I'd say. IMRT buys you excellent high-dose conformity and nearby organ sparing, but the radiobiological cost is the low-dose bath to a larger volume of normal tissue. This is the main driver for the theoretical increase in secondary cancer risk via the LNT model, a key concern especially for pediatric patients and long-term survivors.
Good one. Pearl number two. FLLH radiotherapy is defined by its delivery method ultra-high dose rates, specifically greater than 40 grays per second. That speed is its defining characteristic.
Pearl number three. The major purported biological advantage of FLAH, seen consistently preclinically, is significant normal tissue sparing while maintaining or maybe even enhancing tumor control. The leading hypothesis for how involves transient oxygen depletion in normal tissues during that rapid radiation pulse, making them temporarily radioresistant.
Excellent. Those three pearls really capture the essence of what we discussed for both techniques.
Think those concepts are locked in, ready for a quick board blitz.
Let's do it. Fire away.
Okay, question one. A key radiobiological concern associated with intensity-modulated radiation therapy, or IMRT, compared to some older 3D conformal techniques is A. Reduced dose conformity to the target volume. B. Increased dose to immediately adjacent critical organs. C. A significantly lower integral dose to the patient. Or D. A larger volume of normal tissue exposed to a low-dose bath, potentially increasing secondary cancer risk.
All right, let's break it down. A is wrong. IMRT improves conformity. B is wrong. It's designed to decrease dose to adjacent organs. C is tricky, but IMRT often increases integral dose due to the low-dose spread, so C is wrong. That leaves D, the low-dose bath, covering a larger volume and the associated potential secondary cancer risk. That's the primary radiobiological concern, so D.
Correct. That low-dose bath is central to the IMRT radiobiology discussion. Okay, question two. FLAH radiotherapy is characterized by the delivery of radiation at 2A, very low dose rates, less than 0.1 gray per minute. B, conventional dose rates, 2 to 6 grays per minute. C, moderately high dose rates, 10 to 20 grays per minute. Or D, ultra-high dose rates, greater than 40 grays per second.
This one is straight definition. FLAH is all about speed.
Yeah.
A, B, and C describe conventional or slower rates. D, greater than 40 grays per second, is the defining threshold. Answer is D.
Got it. Ultra-high dose rate equals FLAH. Question 3. The primary biological advantage consistently reported for FLAH radiotherapy in preclinical studies is A, markedly increased tumor cell killing compared to conventional dose rates. B, complete elimination of tumor hypoxia. C, significant sparing of normal tissues with equivalent tumor control. Or D, a significantly higher oxygen enhancement ratio.
Okay, thinking about the core flash effect. While enhanced tumor kill, A, is sometimes suggested, the most consistent finding is the differential sparing of normal tissue. C, it doesn't eliminate tumor hypoxia. B, might exploit it. And while oxygen is involved in the mechanism, saying the advantage is a higher OERD isn't quite right. The advantage is the outcome normal tissue sparing. So the answer is C.
Exactly. That improved therapeutic window through normal tissue sparing is key. Final question, question 4. One of the leading proposed mechanisms for the FLAH effect, which is normal tissue sparing at ultra-high dose rates, involves A, enhanced activation of DNA repair pathways in normal cells. B, selective induction of apoptosis only in tumor cells. C, preferential damage to tumor vasculature. Or D, transient depletion of oxygen in normal tissues during irradiation.
We discussed the main hypotheses. While A, B, and C are areas of research or potential contributors, the most widely cited and leading hypothesis right now is the oxygen hypothesis D, the idea that rapid oxygen consumption during the pulse leads to transient hypoxia and radioresistance, specifically in normal tissues. So D.
Perfect. That oxygen mechanism is the one you definitely need to know for FLAH. Great job on the blitz.
Helps reinforce the key points.
So just briefly touching on controversies or advances, with IMRT, the main ongoing discussion is really about optimizing its use, maybe simplifying techniques where possible to reduce MUs and integral dose, especially in low-risk situations or pediatrics.
Right. And refining our understanding and modeling of long-term risks. For FLAH, the advance is the entire field, really.
Yeah, it's all about advancing it towards the clinic.
Exactly. Overcoming those technical hurdles for clinical delivery systems, performing the crucial large animal studies and early human trials to confirm safety and efficacy, and continuing the basic science research to really nail down the mechanisms. That's where the action is.
It's definitely a space to watch in the coming years.
For sure.
Okay, so let's wrap up. We've covered a lot of ground on the radiobiology of these two important modalities.
We saw that IMRT, our modern workhorse, gives us incredible precision, but it comes with those radiobiological trade-offs. More monitor units, that low-dose bath spread over a larger volume, potentially higher integral dose, and based on the LNT model, a theoretical increase in secondary cancer risk, which is most concerning for younger patients with long life expectancies.
And then there's Elifash, operating at those blistering speeds of over 40 grays per second. Its huge promise lies in potentially sparing normal tissues significantly while still effectively treating the tumor.
With the leading idea being that it might work by causing this rapid transient oxygen depletion specifically in normal tissues during the radiation pulse, making them temporarily resistant.
Both techniques, in their own way, represent the ongoing effort in our field to refine radiation delivery, either through optimizing precision like IMRT or exploring fundamentally new biological interactions like Elifash.
All with the ultimate goal of improving outcomes and quality of life for our patients.
Well said. All right, if you want to test yourself further, remember you can complete practice oral boards over at radonsmartlearn.com.
And be sure to subscribe to Radon Smart Review so you don't miss our next exploration of key radiation biology topics.
Thanks so much for tuning in, everyone.
See you next time.